So my name is Julian Rodriguez. I'm a Perth-based neurologist. I've been practicing since 2005. My interest in headache began in around 2010 when I began treating large numbers of patients with migraine with botulinum toxin. We know a lot about the biology of migraine now. It is a primary central nervous system disorder. So people will come along having been told or believe various different theories, such as it's muscular, it's coming from the neck or the blood vessels, or some people even think it's some kind of sign of psychological weakness. It's not. So when I say it's a disorder of the brain, there's a network of activity that switches on during the migraine attack and causes a cascade of symptoms, nausea, pain, sensitivity to light, sound, etc. And this brain network activates and then it deactivates. So we can see that, it's been mapped on brain scans, so we can tell people that this is a brain disorder. The population that gets migraine is basically across the whole age spectrum. You can have your first migraine at age 10 or at age 80. Having said that, it's more common in women, far more common, and there is a big peak in prevalence in around the 30 to 50 age group, particularly in women, and that's clearly impacting on people at their most productive time of life. The first thing I ask people when they come with a history of migraine is, take me through a typical episode, because everyone is not necessarily exactly the same. Within a patient, the attacks are often stereotyped. They can have more than one type of headache, if you like, and it's even possible to have migraine episodes without headache at all, which then confuses people even more. So the first thing is to get a story from the person. Another crucial component is getting a headache diary. So I like people to walk in with a little 1-month snapshot of symptoms. This helps us actually diagnose what type of headache syndrome they have. They may have migraine, they may have tension headache, they may have an overlap of the two. Diagnosis is critical because that guides further treatment. So there's symptoms of classic migraine. There's many subtypes of migraine. There's classic migraine, which is throbbing, one-sided headache, sensitivity to the environment like bright lights, sounds, smells, any physical activity, even gentle, worsens the pain, so they're pretty much bedbound or housebound. They can feel nauseous, ranging up to dry retching and profuse vomiting and dehydration. The definition of a migraine strictly is 4 hours, but these attacks can often go on for 24, 48 hours longer. So that's the migraine episode. There's another subtype called migraine with aura. I've already said that migraine is a disease of brain dysfunction. Aura means that you get neurological symptoms which we can localize to different areas of the brain. So the commonest one is a visual aura. People will get flashing lights, they'll get a hole in their vision. Some people lose vision altogether, so have disabling sudden visual loss. These symptoms usually precede the headache phase, and they can be a useful marker for when to start treatment in some people. Other aura symptoms can include paralysis, numbness down one side of the body, inability to speak, double vision, depending on which area of the brain's affected. So in some people, the aura can be as disabling as the headache. And as I've already said, you can get people coming in with just aura symptoms which are misdiagnosed as stroke. So that's an important thing to exclude. We always investigate people who have presented with these sudden onset neurological symptoms for the first time. We wouldn't assume they're migraine until we've excluded any other cause. And then the other subtypes of migraine are based on how often people get them. So the commonest variant I'm talking about, so women in their 30s, 40s, 25% of women will have migraine. That's episodic migraine. So it'll come, it'll knock you out, it'll go away, you'll be well in between. You can have attacks of varying intensity and severity and duration, but in general you'll recover in between. The other form of migraine is called chronic migraine. That affects about 3% of the population. It can occur in people out of the blue without any history of migraine, or it can occur in someone with episodic migraine, and we say they've transformed into chronic migraine. So that can occur just spontaneously for no good reason, or triggered by psychological or physical stress, head injury and illness. Non-specific infections or meningitis can trigger headaches, which then go on to become chronic migraine. So there's a range of people and conditions that will lead into chronic migraine. Once people are in this state of chronic migraine, which is the strict definition again is a bit arbitrary, 15 days per month with a headache, 8 of those days have to have features of migraine. But really, it's been shown that anything more than 12 days per month with significant headache reduces your quality of life. So this amount of headache is disabling. People can't function. They do not recover in between episodes as opposed to episodic migraine. And the other thing that's tricky about it is that people will have had their classic migraines in their 20s, 30s, and then in their 40s or 50s or later, they'll drift into chronic migraine, and they don't think it's migraine because it can be a sneaky, subtle headache. It doesn't have to have all the features of migraine. They can have a constant low-grade headache, one-sided or not, and then migraine attacks in between. So it often gets misdiagnosed, particularly in elderly people with neck pain coming from joints or sinus pain and other causes. So the key thing is being diagnosed correctly. So talking about triggers for migraine, there's hundreds of triggers. Looking at individuals, but you can categorise them as, I guess, dietary. So certain foods, chocolates, other things, alcohol. When I'm telling people about triggers, I just tell them to look out for them. The most important thing is that people don't exclude delightful things from their life if they're not a trigger. So being didactically told that red wine is not, or chocolate's not good for you, is not necessarily the case. So that's the dietary side of things. You can enjoy a glass of alcohol without the fear of triggering a migraine in some people. Other people can't, sniff a bottle without getting one. Then there's the sort of metabolic, hormonal type things. So, and in women that's more relevant because there's more hormonal changes during a woman's life than a man's life. So migraine can come on early in life when periods start. They can be purely perimenstrual. They can worsen or improve during pregnancy. If they worsen during pregnancy, that's a problem because we're limited with the medications we can use to treat it. And then again, when people enter perimenopausal period, that can be a period of several years of hormonal ups and downs, and migraines can be reactivated during that period of time. In general, we make generalizations and we tell women and men with migraine that your migraines will improve as you get older. And that is true for most people. But I see the people where that rule is broken and they're in their 50s, 60s, 70s still suffering from migraine. So yes, hormones definitely play a part.